The hospital system is not set up to benefit that individual woman. The hospital system is set up to benefit the hospital system. We can talk about continuous fetal monitoring. It was designed, supposedly, without research, that it was going to prevent cerebral palsy or interpartum death. It has done neither. What it has done is it's increased intervention rates by
Welcome back to Healthy as a Mother. I'm your co-host, Dr. Morgan McDermott, and this is the show for becoming and being a mother, where Dr. Leah and I share the natural women's health and motherhood guidance that you've been looking for through our fresh, functional, and balanced lens. And today on the show, we have a very special guest, Dr. Stuart Fischbein. He's an OB-GYN who, if you've been in the natural birth space for any length of time, you've definitely heard of him. And if you haven't, now you have, and you need to know him because he trailblazes the space of vaginal breech and vaginal twins. And today we talk all about, why the system is the way that it is. How do we break it? Some of the historical contexts and the studies that have forever changed the way that those two populations of birth, breech and twins, are able or not able to within the hospital system. We had a lot of other plans for the podcast and it kind of went in many different ways. It was a fascinating conversation and I think you're really going to enjoy it. So let's dive in. Okay, welcome to the podcast, Dr. Stu. This is a really big deal for me because I've been following your work for a long time, as I'm sure that a lot of people say to you. And it's just really cool to talk to somebody who's such a trailblazer in this movement. And I feel like you're a little bit of a hybrid, right? Being an MD, an OB-GYN, but then working so closely with midwives and having this physiological birth pro view and lens on things, especially with your expertise in breech and twins. It's just a fantastic blend because you really have the experience to say you've come from XYZ thing in the hospitals and moved through to see this other thing. And you have all of the experiences in between. So thank you for being here.
Morgan, thanks for having me. It's a great honor to speak to an audience that sometimes I might not otherwise reach. I am a bit of a hybrid. I'm retired now, so I'm a retired hybrid. The problem is most people in the birth profession are siloed, and they never are exposed to other ways of thinking. And what's really a problem in our system right now is that everything has become so medicalized, so algorithmic. Doctors are just employees working shifts. The patients are just lives. They're not individuals anymore. That individualization of care and that the idea that there are different ways of doing things have been taken away from doctors. Doctors used to be what I call shepherds and captains of their own ship. And now I think most doctors as employees are just sheep. And they're basically told what to do. The policies are made by administrative people and risk managers and that sort of thing. And then they have to follow the rules. So they're not going to open their minds to the idea that there are different ways of doing things. And ultimately, no matter what the system is comfortable with, the decision of how to proceed belongs to the independent woman.
Yeah, I love that. Their hands are tied.
They don't respect that.
Yeah. And even if they wanted to do something different, like you said, it's so much the hospital having policies, yes or no, and an individual doctor may have the skill, wisdom, experience, comfortability, overall knowledge and insight to say, no, this could go a different way if only I was allowed, quote unquote, in this hospital to maybe support a vaginal breech or vaginal twins birth. And it's a dying art, all these things that we know. And we're going to get into that in a second. I do want to just read a quick bio so that the audience is familiar with you in case they're not, which they definitely need to know who you are. And I will put all of Dr. Stu's information in the show notes too, so you can follow him on Instagram. You can also listen to his podcast, which is amazing. It's called Birthing Instincts, and it's co-hosted by a midwife named Bliss Young. So let me just read this real quick bio here because I think it's impressive. Stuart James Fischbein, MD, is a published author of the book Fearless Pregnancy, Wisdom and Reassurance from a Doctor, a Midwife, and a Mom, and peer-reviewed papers called Home Birth with an Obstetrician, a series of 135 out-of-hospital births, breech birth at home, birth outcomes of 60 breech and 109 cephalic planned home and birth center births and twin home birth, outcomes of 100 sets of twins in the care of a single practitioner. So these are different titles of papers, 3 different titles of papers. I kind of didn't read that last home birth one with twins very well, but
they're a mouthful, yeah.
Yeah, they're a mouthful. I'll put them though in the show notes too so people can read them because I think for those that are very evidence-based, research oriented, or they really need to see it, or they're data driven, or maybe also sometimes for the partners, sometimes women are maybe feeling really pulled in one direction. And then if they have a male partner, they're like, no, this is not safe. I don't want to do it, But to be able to see it written down in a peer-reviewed way can be helpful to show that, no, this is absolutely a possibility. So he spent 28 years assisting women and with hospital birthing. And then for the next 12 plus years was a home birth obstetrician. So cool. Who worked directly with midwives. Since recently retiring from attending home births, he has turned his focus to traveling around the world as a lecturer and advocate for reteaching breech and twin birth skills, respect for the normalcy of birth, and honoring informed consent. He hosts the weekly Birthing Instincts podcast and with co-host Bliss Young. So Reteach Breech is a workshop that you teach to birth workers all over the country. And the name is brilliant because it was something that people knew. And now it's one of those things where they just don't. And maybe it's, as we were earlier touching on, because of the hospital birth kind of cuffing these practitioners who would otherwise feel comfortable, or at least in attempting. It's like there's no attempt. There's no, hey, let's try this, or maybe even let's give birth in the OR. Let's try and see. And, if something is going awry, we can make a real quick adjustment. Although, no woman necessarily wants to give birth in the OR. It's not a very comfortable place, but, they don't even, what's going on with that? Why is there zero attempt? It's an automatic cesarean for these situations.
Okay. I'm going to answer that in just a second. I wanted to just talk about you mentioned my research, my observational practice studies that I put out. They're all open access, so they're free. And the problem is research right now is so corrupted that people are going to have a hard time if they Google search or do anything, knowing that a paper has any legitimacy. I'm not just tooting my own horn when I say my papers are not big enough to reach what's called statistical significance. They're observational of my own clinical experience, but I'm not sponsored by anybody. I wasn't sponsored by the NIH or Big Pharma or anybody else to put out a paper to encourage people to do this. I'm just relating my own experiences. So for the average consumer to try to figure out when they we always tell people to do their own homework. The question is, how do you do your own homework? Do you go to ChatGPT? No, you can't, because ChatGPT is programmed by people. You have to challenge ChatGPT. Do you go to Google search? No, because Google search, the engine is designed to push you toward whatever the majority narrative is. So just research in general is very difficult. It's very difficult in this day and age when we have access to all sorts of information to actually know what's true anymore. I just want to say that. So again, it's a disclaimer for people looking into, they may have a birth where their doctor has told them something that's very scary. And how do you find otherwise? And again, it's not an easy thing to do. So we're going to talk about some of those things today. And you mentioned reteach breech and why did breech disappear? So let's start with that. When I was training, it was the early 1980s, breech was just a normal variation. And I did my residency at Cedars-Sinai Medical Center in Los Angeles, and we were affiliated at that time with LA County USC Women's Hospital, which was the busiest hospital in the United States in the early 1980s. We did about 22,000 births a year there, which if you break that down is about 65 babies a day. Now we know breech at term is about 3 to 4%, so we're seeing 2 or 3 breeches every day that were on call. And I was there for 4 months every other day, so you can figure out the math. And it was just considered normal. As a matter of fact, we used to put our dibs on somebody. I get the woman in room 4 because I want the breech delivery, and I'm taking that because they were fun. We got to actually do something. Because in those days, women were on their back, and once the butt was showing, we did maneuvers to get the baby out. We didn't believe in this upright, hands-off breech delivery that works really well for most women in labor. Obviously, hands-off is not something that should be all-encompassing. We might get to that later. So it was just considered normal. And there was a debate going on in the late 80s and early 90s of which is better, a C-section for breech or vaginal delivery for breech. And there were papers, as I said earlier, research depends. Sometimes research is blind and they look for whatever the research takes us. And sometimes research is designed to get to an end point that they want. And I think that's what happened in the late 80s and 90s. For some reason, the maternal fetal medicine doctors who ran the residency programs decided that, and maybe because of risk management and maybe because hospitals made more profit off of C-sections, all kinds of different reasons, the vaginal birth of breech began to fall out of favor. There were papers that supported vaginal breech delivery, properly selected, and there's criteria for that. And they were all listed in my paper. And there were papers that said, no, cesarean's better. Of course, those papers never looked at downstream consequences of cesarean. They just looked at neonatal morbidity and neonatal mortality, which is what most papers look at. They didn't look at how's that baby doing at 1 year of age or 5 years old. What's the baby's chronic illness rate? What's the microbiome? How did that mother do? How was the breastfeeding with that mother? How was her postpartum recovery? Did she have depression or did she experience trauma? How did she do in her future pregnancies? Did she have a problem with placental implantation? Did she have a ruptured uterus and have a bad outcome because she had a cesarean section for breech? Never studied, never looked at. Because all they really care about, this is my signature statement, is a live baby in the bassinet and how the baby gets there. And what happens with that baby, that mom, and that mom's future babies is not the concern of the medical system. So in 2000, it's often credited that a paper came out called the Term Breech Trial. It's out of Canada, but it was 126 centers in 22 countries. It was supposedly randomized, but it was a very poorly controlled study. And there's lots of flaws, and there's many articles out there that point out the flaws of this study. But it came out showing that C-section was better for outcomes, fetal morbidity and mortality, than vaginal delivery. And because it's what the system wanted, it was immediately adopted. And within months around the world, hospitals stopped allowing breech delivery. Residency programs stopped teaching breech delivery.
Just like the ARRIVE trial.
Well, the ARRIVE trial was also bad science. And again, I don't know if it's the depth of this podcast to break down why the Term Breech trial was so bad, but just some simple things about it where they randomized you in labor. So what if you came in labor thinking that breech is dangerous and you get randomized to the breech vaginal delivery group? That's not a good start. There was no consistency on protocols for breech delivery. There was no consistency on the skill of the person who's managing the breech delivery. One of the requirements of these was to have a baby having a flexed head. 30% of the centers did not have an ultrasound in labor and delivery to determine if the baby's head was flexed. Yet these were all included in it. And even though in the years following this paper, multiple papers came out that were better controlled, that fixed the problems of the Term Breech trial, that were much larger than the Term Breech trial, came out and said there's essentially no difference in outcomes for babies delivered vaginally or by cesarean in breech position. Those papers were ignored, and the precedent was set. And since that time, no doctor in residency training in my country is going to get enough training in breech delivery to feel comfortable doing it. And even if they did, they're going to end up coming out now no longer being a self-employed doctor. They're going to come out being an employee for a system that says you can't do breech delivery. So the tragedy of all that is that despite their aversion to breech delivery, many women are going to walk into labor and delivery with a breech, premature breech or a term breech where the baby's foot or the baby's butt are beginning to protrude, and they're not going to know what to do. And that's going to be a real tragedy, because then they're going to shove that baby back up inside. They're going to take the woman to the operating room. They're going to gas her. She's going to have no memory of her birth. She's going to have a traumatic C-section. They're still going to have to pull the baby out of her abdomen in the breech position, not knowing the cardinal movements of breech, not knowing a safe way to deliver breech. As a matter of fact, in the Term Breech trial, there were some serious injuries, not that many, but most of them were babies born breech at cesarean section.
Why is that? Because when they're halfway lodged?
Because they just pull, they yank, and the head gets extended and they get brachial plexus or neck injuries because they don't know that the proper movement to deliver a breech head is by flexion. They need to pull they need to flex the head, not extend the head. And they don't know these things. And they just think, well, she's having a C-section, I could just cut a bigger hole, or I can just tee the incision. And of course, when they tee the incision, then they tell the woman that she can never have a VBAC.
That means like making a big T across the abdomen, just so that everybody doesn't know what that means. Like,
no, not the skin. This is the uterus. It's not the skin. It's still a low transverse skin incision, but they do a low transverse incision in the uterus, and then they go straight up to make a hole bigger so they can get the baby out. And again, these things are not that common either, but none of this is necessary. And in my experience, 80% of first-time moms slightly higher than that, 80 to 84% of first-time moms will be successful. And in my experience, again, this wouldn't carry on if I carried on forever, but I had 100% success rate with women who'd already had at least one vaginal delivery with a properly selected breech at term. So if you're going to section, you're sectioning 100% of multips and 84% of primips who don't need to be sectioned are getting sectioned because they don't know how to do breech delivery and they're scared of it. And because they're scared of it, they project that fear onto the population and the American public. You know, if you ask somebody about breech, first of all, a lot of people don't even know what it means. But if you tell them, oh, it's butt first, immediately they'll say, oh, that's too dangerous, that's scary. And it's not.
What is it about a breech baby coming foot or butt first in a vaginal setting that makes it more dangerous, or this thought of it making more? Is it simply because the head can sometimes get stuck and it's difficult?
Anthropomorphize. I just screwed up the word.
Anthropomorphizing?
Okay, thank you. God. Certain words you have a mental block when you try to say them. If your head were stuck in a log, you'd be panicking because you'd worry about suffocating. What they're not remembering is that the baby is not breathing. The baby's getting its oxygen through the umbilical cord. So there's this panic when the head comes out last. There's also a slightly greater risk, not that high, about 1 in 250 chance of the cord prolapsing. And cord prolapse, although more common in breech delivery, isn't as emergent as it is in head down delivery because it's less likely to be compressed. It's still scary to see the cord hanging out when a woman isn't completely dilated. If she's completely dilated and the cord is hanging out, you can just reach up and pull the baby out. And again, it's a skill that I was trained to do. And that's one of the things we teach at the Reteach Breech. We have these beautiful simulators. And we spend a lot of time in talking, and then we spend a lot of time using hands-on training. But you can reach up and pull them out. So those are the two things, mainly that the head's going to get stuck or the cord will prolapse. And doctors these days, there's no reward for them doing a vaginal breech birth. All the rewards are towards cesarean section. You save time. You get paid a little bit more. Now, whether the doctor gets paid more or not isn't that important. The doctor saves time. He can be in at 7:30, out by 8:15, back into his office by 9. The hospital gets paid more money. There's a perception that it's less liability. And I just recently had an interview with a maternal fetal medicine specialist, and she said the biggest fear of doctors is not a dead baby or a dead mother, as awful as that sounds. It's a critically injured baby that needs a lifetime of care. And so when you deliver a baby by cesarean section, if that baby develops asthma or other immune problems down the road, that's not the concern of the obstetrician. What they don't know is that the outcomes for the babies as far as their brain is really not statistically significantly different if you make proper selection of your breech clients. But they don't know these things anymore because they're not taught anymore.
So let's talk about that proper selection of a breech client. What is it that needs to be sort of in place for it to feel like a very comfortable, safe situation for a breech?
Well, the world literature suggests that any baby above 32 weeks that's breech, there's no benefit to cesarean section. You're not going to find anybody that's going to suggest that. And certainly we didn't do 32 weekers at home. So my criteria listed in my paper, there's about 8 or 9 of them. If I can see if I can remember them off the top of my head. One is they need to be term. So term for me was 35 weeks and above. Now, there are many states that have laws that say a midwife can't take care of anybody until they're 37 weeks, which sucks if you're 36 weeks and 5 days and you're in labor with a breech baby, because you could have a home birth with your midwife. You go to the hospital, you're going to have a C-section.
35 weeks seems young. Why go down that low, or why choose that?
Because the only option they have if they go to the hospital is a cesarean.
Okay.
Most 35-week babies, when they come out, do not need respiratory assistance. Some do, but it's usually not that emergent type. So if they're, an hour after birth, they're still breathing fast, or they're, retracting a little bit, and then they go to the hospital. But at least they had a vaginal delivery, and they had an hour of delayed cord clamping, and they had an hour of skin to skin with their mom before they got separated from their mom. Where in the hospital, a 35-weeker almost automatically is going to go to the NICU.
Yeah, and these are the types of effects that infuriate me, that they're not accounted for in the overall experience and health of what's happening. I mean, obviously, in a situation where a baby is rapidly declining and needs life-saving treatment, that's different. But that is not the case in so many situations where they are being separated for hours and hours and hours, if not days. And no account of the baby's well-being is being taken into into consideration there?
There are 3 positions that are acceptable for breech delivery. One is frank breech, where the legs are sticking up by the face like this.
Like a little pike, like a little gymnast in a pike position.
Yeah, where the hips are flexed and the knees are extended. And then there's complete breech, where the legs are crossed.
Like a little just kind of crisscross applesauce up by the stomach.
Correct. And then you could have what's called an incomplete breech, where you have one leg down and one leg up. And all 3 of those are perfectly reasonable with a term pregnancy to deliver vaginally. Now, people will say, well, maybe it's the butt's so small and the head's so big. I will tell anybody, if you have a term baby and you want to just try this, take a tape measure after your baby's born and measure the circumference of the baby's head, and then take the tape measure and go around the baby's butt and 2 thighs, or even 1 thigh. You'll find that the circumference is actually bigger of the thighs and butt than it is of the head. So frank, complete, or incomplete breech, all right? And then baby needs to be an estimated fetal weight. I just threw out in my paper somewhere between 5 and 9.5 pounds. A lot of guidelines in more restrictive hospitals that still allow breech, they'll say nothing over 8 pounds, which is ridiculous. First of all, estimated fetal weight is really unreliable. So to section a woman because you think the baby's over 8 pounds or over 9 pounds, and then you end up with a 7-pound baby, and then you feel like an idiot, but you don't actually admit you're an idiot because that would be too hard. And then 5 pounds. But if I had a woman that I thought had a 4.5-pound baby, would I tell her she has to have a C-section? No. But when you're writing a paper, you have to kind of put some guidelines in. So that's what I would do. But remember, down to 32 weeks, which is about 1,500 grams, which is 3 pounds, 5 ounces. The world literature does not support doing C-section for those breech babies. People don't know that because doctors don't know that. Doctors are scared.
With the smaller ones, is it because they are not ready enough to be out in this world, or is it more because of the cord prolapse idea?
No, it's more because their body is smaller than their head. And head entrapment is something that can happen when you have a preemie like 29-weeker or something like that. So that's those 3. The next one is the baby should have a flexed head. Baby doesn't have to have its head flexed all the time. We just have to know the baby's head is able to be flexed. Sometimes babies have a goiter. These are rare things, or torticollis, which is a spasm of the sternocleidomastoid muscle, and their head's always extended. Or they could have hydrocephalus. That's why an ultrasound is, doing a breech delivery without an ultrasound is probably not wise. So for those women that don't want any ultrasounds at all and you have a breech baby, if you want to find a practitioner who's going to support you, to be safe, they really should recommend one screening ultrasound, hopefully with a friendly ultrasonographer, so you don't get freaked out by the maternal fetal medicine doctor who tells you breech is dangerous and all that other things. That's one of the fears of midwives, is having to send your patient into the medical system. Anyway, so that's flexed head. Let's see. No gross anomalies. So in other words, we don't want a baby with hydrocephalus or spina bifida or abdominal wall defect or anything like that. Crazy one is something called adequate maternal pelvis. Right now, in the medical model, when I was a resident, we took women for X-ray pelvimetry when they were in labor. It was one of the dumbest things you could do, because we know, first of all, now that when a woman is upright, her pelvis has 20 to 30% more space in it than when she's laying flat on her back. But when you go for an X-ray or now an MRI to check your pelvic dimensions, you're laying flat on your back. And then we'd measure the intraspinous diameter, the AP diameter, and the transverse diameter, and they had to be 10, 11, and 12 centimeters or above. And if one of those measurements was less than those 3 numbers, then they got a C-section. So we sectioned a lot of women who didn't need C-sections because we were following a protocol when I was training. So to me, a clinically adequate pelvis, and I don't mean this farcically, but is a woman with a pelvis. Unless she's had the crushing ski accident or car accident where she has pins or things where the pelvis isn't going to move, or she has some congenital, which I've never seen. Maybe she has rickets. We don't see rickets.
In most cases, the pelvis is going to be adequate and fine.
Right. We'd like to see labor progress spontaneously. We don't like to induce breaches. And obviously in the home world, we really don't. Have we done castor oil with breaches and sweeps, membrane sweeps? Yes. But we prefer not to. And then, because we're partly because we are under a lot of scrutiny and we don't want to push the envelope. But in the hospital, like you said, you have an operating room down the hall. You could get the baby down there if there's a problem. I don't like induction anyway for anything. Obviously it's necessary.
I don't either. I just wanted to know, is there something specific with breech, or is it more just that it raises all complications? So why go there?
I think it's just one of those things that probably I haven't really thought about that much. I've sort of just stuck it in there because I don't want people pushing the envelope and then we getting bad outcomes with breeches. And then they say, see, we told you. So, and obviously a no-brainer is mother and baby need to tolerate labor. If mom isn't tolerating labor, baby isn't tolerating labor, that's a no-brainer. That's the same thing. Those are the same thing you'd have for a head down baby anyway. These are not different. And then, of course, the right mindset for the parents is very, very important. You can't take somebody who was planning a hospital birth with an epidural early on, who finds out she's breech and says, okay, well, my only option for breech is a home birth, so I'll do that now. But I'm scared out of my mind of the idea of a home birth. That's not a good candidate for a home birth, let alone a breech home birth. So those are essentially the simple guidelines.
Thank you for outlining all of those. And it reminds me of a story of my first midwife. I had all 4 of my babies at home, different midwives, except for the last 2. That was the same midwife here in Idaho. But the first one had this really amazing story to tell because I asked her as a first-time mom, and I was very young, well, what would happen if the baby was presenting breech at delivery? What do we do? I was in California. I knew that it wasn't going to be something that would be supported, but I wanted to know how she would handle it. Would she send me off to transfer and call 911 for an ambulance, or would she just deliver the baby and we'd be done, And she told the story of a mom who was in the bathtub and the student midwife went to check because she started to push, and student midwife was a little bit iffy on what she was feeling. So she whispered in the ear of the main midwife, I don't know what I'm feeling. So midwife goes and checks and it's a butt. And the woman had specifically said, if anything is going on weird in the labor, I don't want to know. Do not tell me. Just help me through this situation. And so they all kind of convened. She was, off in labor land. She wasn't paying attention. Dad and midwife and student midwife all kind of convened. They're like, okay, this is what's happening. The baby's coming out breech. Let's get her up in this chair. Nobody say a word. And the dad is obviously wide-eyed, like, what's going on? And she's like, it's fine. It's fine. So they get her out of the bathtub. They sit her up in a chair. Nobody said a word to her about what was happening. They didn't even mention it. And she delivered the baby. And then minutes later, after she was having this moment with her baby, they told her, hey, did you even know? Like, the baby came out breech. And the woman was completely shocked. And I really think that is a respectful way. Maybe some people will be like, wait, what? Why wouldn't you tell her? And it's like, because that is it can be fearful in that moment and you don't know what it means. And it's like, what's the point in spiking some sort of adrenaline when you can just keep her in this? She was doing beautifully beforehand. And I just love that care for the room. Especially as she requested not to be not to be told. I mean, ultimately, that's the beauty of having a relationship between a caregiver that and some stranger that's working a shift. And I have to give a lot of credit to your caregiver, how calm she was to that. That caregiver, not your caregiver, but that midwife who was helping her. Clearly, she was skilled. Clearly, she was calm. Clearly, she knew that breech is not something that is necessarily a problem, and she wasn't freaked out by it. So all kudos to both the mom, the dad, for not panicking, and to the midwife team to get that baby out safely. Now, again, in a surprise breech, a lot of the criteria that I just went through, you don't know. You don't know. Did she have an ultrasound? Does she have a flexed head? Are there anomalies? What's the estimated fetal weight? You may not know certain things, but at that point, you just go with the flow. Yeah, you're just present to the moment and you're just doing the best that you can. And it's important to have the skills because maybe a third of babies, not quite that many, might need hands-on rotational maneuvers, sweeps, get the arms out, do things to get the head out. Whereas about, at least 2/3, especially higher in multips, the baby's just going to fall. They're going to fall on the bed, right? If you are looking for a delicious and effective supplement to help support the immune system of your entire family, from children through adults, including pregnancy and breastfeeding, look no further than the Needed Immune Support Powder. With elderberry, zinc, pre- and postbiotics, arabinogalactans, and beta-glucans, this berry-flavored powder can be enjoyed on its own, or it can be mixed into smoothies, juice, sprinkled on yogurt, made into popsicles, or even gummies. It's something that I always keep on hand as part of our wellness routine, and it can support you through the entire year. Give it a try by going to thisisneeded.com and use code HEALTHYMOTHER to save 20% off your first order. Again, go to thisisneeded.com and use code HEALTHYMOTHER to save 20%. Yeah, you mentioned earlier that there is certain situations where hands-off breech delivery is not right. Can we talk about that a little bit? Because I think that is something that people think, oh, well, if your baby, especially maybe in the free birth or more autonomous birth settings, they're like, oh, well, if your baby's coming out of breech, just turn over, get on your hands and knees, don't let anybody touch the baby, and it'll hang and then it'll come out. And it's like, well, maybe most of the time, but let's talk about some of the situations where that might not be the case.
Yeah, Morgan, hands off the breech came as a response to the fact that we were all meddling with breech too much. So the pendulum was way over here and then it swung way over here. And that was a mistake as well. Because when you have a woman who's delivering breech in the upright position, you have gravity working for you. But there are certain things that babies will tell you that they need help. And they're very obvious. And the beauty of a breech birth is that you can actually see the baby. You can see the tone. You can see the color. You can see whether it has capillary filling, which is what everybody knows what that is. If you have a sunburn and you push on your skin, it blanches, you take your finger away, it turns pink right away again. That means you're perfusing, your heart's beating, that sort of thing. That's good. Is the baby doing tummy crunches? What does the umbilical cord look like? Is the baby rotating the proper way? Babies will almost always come out facing sideways. Their back will face mom's thigh. And as they come out, by the time they reach the umbilicus, the belly button, they will rotate so that their belly is facing mom's bum. We call it tum to bum. And if the baby stays sideways, which is called sacrum transverse, that means almost always that the baby's arm, at least one or both of the baby's arms, are up behind the head as opposed to generally just sitting in front. In utero, if you've ever done a scan on a breech baby, the arms are always in front of the baby. No baby sitting in utero like it's lounging with its arm behind its head. They just don't do that. What happens is they come down, an arm gets caught on something and gets pushed behind the head. And when it does that, it prevents the baby from doing its cardinal movements of its rotation. And so then you need to know how to go in and rotate the baby and sweep an arm and then rotate and sweep the other arm. And then depending on the baby's hanging in upright position or the mom's on her back, then you have certain maneuvers that you do for the aftercoming head. Those are the skills. They're not hard to do. I could teach any medical resident or doctor those skills in 2 hours with a simulator. Less than 2 hours. If it was one-on-one, I could teach them in 30 minutes. But they don't want to learn it.
And even if they did know it and they wanted to do it, their hospital probably won't let them.
But as I said earlier, every now and then a woman's going to come in and with a butt sticking out or a foot sticking out, being completely dilated. You have to be completely dilated to do these maneuvers. You can't do them when they're not completely dilated. Then a C-section is warranted if the baby's in trouble, or you could continue to wait depending on the situation. But they're going to come in and they're not going to, and they could have that baby out literally in 15 to 30 seconds. But no, they're going to take 8 to 15 to 20 minutes to take the woman to an operating room, get her anesthetized, get an OR crew in, cut her open, pull the baby out, breech, when they could have had the baby out in 15 to 30 seconds if they had the skill.
And what about when there's a foot coming out? What do we think about that?
Well, at term, that's generally a complete breech with a foot that's dropped. It's very hard to have what's called a footling breech, but you need to know what the cervix is. So if you see a foot, you'd examine it. Now, if she's only 6 centimeters and the foot sticking out and the baby's heart rate's fine,
just wait.
Then you just wait. You just wait. Knowing these skills is what makes an obstetrician an obstetrician. I've been very critical of my maternal fetal medicine colleagues for not, they run the programs, they run the teaching programs, for not teaching this. They're teaching fear rather than skill. And because when you count in twins and term breeches, about 5% of term babies of term pregnant women will have a breech baby. That's 1 out of every 20 women that walk into your office when you're an obstetrician. And you don't have the skills to offer them a reasonable choice. I just think that as an obstetrician, I would feel embarrassed. I'd feel angry at my residency program for not teaching me that. I would feel like mad at myself for not going out and learning the skill and saying, listen, I can't offer you a breech delivery in this system, but you have the right to show up at the system and decline a C-section. And if you do, I'm skilled that I know what to do and when to do it and when it's not okay and when a C-section is indicated. But they don't give them advice like that.
I think it's easier for them to, instead of taking accountability, like you're saying, to fall back on, oh, it's dangerous. Well, I heard it was dangerous. Nobody does it. It's mob mentality of no one does it. It's not right. Sections are easier. outcomes are better from some corrupt study from 100 years ago. Not 100, but you know what I mean? I'm just exaggerating. It's so interesting how the human mind wants to just fall into these groups instead of do what's right and what's moral. Are there any situations where you meet doctors who are like, wow, yeah, this is really messed up, and then they sort of trailblaze like you?
What you were describing about them ridiculing people who do breech delivery or saying it's dangerous, something like that. In my course, when I teach my 2-day seminar, one of the lectures I give is about why doctors feel this way. And one of the things I talk about is cognitive dissonance. And one of the ways to manage cognitive dissonance, what that is having thoughts that conflict with each other. So in other words, you're told your system doesn't allow breech delivery, but you know in your heart that breech delivery is a reasonable choice. So how do you get away with that? Well, you say, well, my system won't allow it, or it's dangerous, or only crazy people do breech delivery, or whatever. That's a way of coping with cognitive dissonance. It's a way of dismissing the anxiety you feel within yourself and making it into consonant cognitions, which is like, well, why would I do that? Only crazy people do that. So then I've convinced myself it's okay. So my doctor colleagues don't realize that. They are in a mass formation. Essentially, they want to belong to their group. They want to be a member of ACOG. They want to keep their board certification. They want to keep their job. And if that's the way they have to do it, then they're going to keep their head down. They're not going to look to alternatives. And they're going to scoff at a woman who comes to them and says, I have monodi twins and I don't want to be delivered at 36 weeks. I'm just going to wait. I'm going to wait till I go into labor. If you can give me a reason other than algorithms why I need to be delivered at 36 weeks, fine. But barring you showing me that there's a problem with my pregnancy, I'm going to wait. That makes them really uncomfortable. It makes the doctors really uncomfortable. And so what do they deal with that woman? They label her as non-compliant. No, she's exercising her sovereignty and her autonomy, and she has the right to do that. And as a matter of fact, all you doctors who follow ACOG guidelines, ACOG guideline number 664 tells you all about ethics and all about never using coercion and about the right of a decisionally capable person to make their own decision and about your obligation to respect their autonomy in decision-making. And yet you completely ignore those ACOG guidelines that you choose not to want to believe, and you only follow the ones you believe, which again is hypocrisy beyond belief. You don't follow ACOG guidelines, you follow the ones you like, and you ignore the ones you don't like. And I'm guilty of that too. I don't follow ACOG guidelines because I think ACOG is corrupt.
I love your comments on ACOG on your podcast.
Oh, they're still recommending COVID shots for pregnant women. They're recommending that women who don't want to have a period just take birth control pills, as if there's no benefit. And we're finding out now the toxic effect of Depo-Provera and birth control pills that ACOG is still all in on.
It's like ACOG's recent statement about the Tylenol situation, which was like, no, it's a totally fine and safe and healthy thing to take. And it's like, hold on, ACOG should at least be saying, take the minimum dose you can in the as least, in the fewest instances that you can in your pregnancy. If you need pain or fever medication during your pregnancy, it is the only recognized as safe. You cannot take ibuprofen or blah, 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 blah. Like to just come out and say, no, safe and effective, that's it, period. As a medical, that's where I was so disappointed in that. I was waiting for them. I was like, what are they going to say? How are they going to say it? They better be complete. And they're so incomplete with their statements.
Yeah. Well, they've basically, they won't use the word woman anymore either, which is a big deal for me. The pregnant person is what they say. But they even say that you can get your flu, by the way, flu shot just came out this week. It was never licensed for pregnant women. So it's off-label use. ACOG was all against ivermectin for off-label use. They're pro-flu shot, off-label use. And they're pro-DTaP shot and they're pro-COVID shot. And they say, by the way, you can give them all at the same time. And that's perfectly safe. Now, there's no safety studies on any one of them individually, let alone giving them the synergistic effect of giving 3 at the same time. But they say that. So why would I, if they proselytize themselves for that and they've broken trust for that, why would you trust them on anything that they say? I mean, sometimes they're right, but maybe not for the right reason. I don't know.
Yeah, well, it just shows that overall as an organization that there's obvious inconsistencies that we can see as the citizens. And it's like, it's almost insulting. It's like, do you not think that I can see what you're doing here? Or do you think I'm stupid? I don't understand why, and this is where the CDC, the WHO, everything has lost a huge amount of trust and legitimacy worldwide because they don't come out and have accountability. It would be so different. At least I think, maybe I'm wrong. I'd love to know your opinion on this. If they said, hey, we don't have these studies, but if you want to, we see clinically that women overall tolerate this vaccine is probably a good idea to spread them out, but it's up to you, informed consent. And if you want this, then here's the studies about that, XYZ. Okay, so like DTaP specifically, did you know that then when your baby goes to get vaccinated at 2 months, the efficacy of the pertussis portion of that vaccine is less because you got the DTaP in pregnancy? Do they tell them that? No. And it's like women have to find this out through podcasts like this or some sort of something. And this is in the research. I'm not making this up. So then they find this out and they go, well, what the hell? Why would they not tell me that? And it's not that they didn't know. It's incomplete information left and right and center, and it's exhausting. And I really feel for women and just people in general who are trying to navigate this system at large. And I love that you brought up, and this kind of just ties back to the earlier conversation about that one study that ruined everything for Breech in this country. It's like, what? And so when people find this out, it just blows up their paradigm.
Yeah, they cherry pick their data, and actually, when you mentioned the DTaP shot, this is a really interesting one because they sent out it was before COVID, so it was probably 2019. They sent out an email. I'm a member of ACOG, so I get their emails. And they sent out an email that said about DTaP counseling and that you should counsel your women to get the DTaP shot. And that if you counsel them and they choose not to get the DTaP shot, that you must have counseled them wrong. They actually said that. I have the email. And then they sent out, more recently during COVID, they sent out an email about something called motivational interviewing. Okay. Now, this is a very twisted use of language. It sounds very pleasant. But what it is basically skewing your counseling to get them to do what they want you to do.
Coercion.
Yeah, well, that's subtle coercion is still coercion. And that's what it is. But they call it motivational interviewing, to get people to take the DTaP shot. And yeah, with no concern the fact that it has, 400 micrograms of aluminum in it, I think. Not to mention the efficacy issues that you talked about. Not to mention, by the way, if you or I, the whole rusty nail thing is probably a lie too, but if we stepped on a rusty nail, we'd want to get I was a kid, they told us you get a tetanus shot. When I was a kid, you could get a tetanus shot. Now you have to get pertussis and diphtheria at the same time, as you don't need it, but you have to get it. But if you got a tetanus shot and then you stepped on a rusty nail next year, they'd say, well, you got to read this tetanus shot within 10 years. You don't need another one. However, if you're pregnant, you get a DTaP shot. If you're pregnant again a year or two later, your OB is going to tell you to get another DTaP shot. So how is that good for you? How does that even make any sense? You have immunity, which you're passing to your baby already because you got a DTaP shot 2 years ago. If you don't have immunity, then what the hell is the use of the shot in the first place?
Yeah, they say, well, it has a short efficacy or a short life in the body. And it's like.
And before they give you the DTaP shot, did they actually check to see if you have immunity to pertussis already? No. You might already have immunity. Oh, well, we want to stimulate you so you can send more antibodies. Well, how long does an antibody last? How fast does the body break down an antibody? I don't know. But does anybody know? Does anybody care? No. Because ACOG, whether it's the appearance of conflict of interest or whether it's true conflict of interest, takes money from Big Pharma. They take a lot of money from Big Pharma. They took a lot of money from the NIH to promote the COVID vaccine to pregnant women as low-hanging fruit. Because if you could get pregnant women to say it's safe, the organization that takes care of pregnant women, then, well, if it's safe for pregnant women, it must be safe for everybody else. So we know at least through FOIA, at least $11 million from the NIH, and I gotta believe there's a lot more than that. I mean, how much is your soul worth, members of ACOG?
So for informed consent, and as an OB-GYN yourself, if I'm a patient, I come to you, I have twins, which we can talk a little bit about twins now too, and you don't think it's a good idea. I have mono twins or something, where it's maybe not the best. And which means that they're in one big sac, and then they also are in one amniotic sac or with one placenta.
No, that's mono die.
Oh, sorry. What am I trying to think of where they're all in one?
Mono, they're in one sac. There's only one amnion, one chorion, two babies inside one sac, right?
And that is not a mono. Is that the one I'm thinking that's the more dangerous one for vaginal birth?
Oh, are we talking about twins, danger with twins or breech with twins?
Just twins in general, vaginal birth. I was going to give an example about, like, which one is it that of the forms of twins that would be the least desirable for vaginal birth?
Well, it depends who you're talking to.
All right, for you, I guess.
Okay. There's no data. Well, I shouldn't say there's no data. There is data supporting vaginal birth of twins, whether they're mono die, or die. So it depends which data you want to choose.
Okay, that's good to know.
The standard teaching for this rare indication of mono twins, which is about 1 in every 300 sets of twins or 1 in every 10,000 births. It's very rare, mono twins.
So if I come to you, let's just pretend a scenario where I have mono twins, I want to give birth to them vaginally. You're not comfortable, or you say, no, it's not a good idea, but I'm your patient. And with informed consent, you would chart that you've counseled me, that we've talked about it, that I denied the cesarean that you planned at whatever weeks. Do you as a practitioner get in some kind of trouble, or does the hospital disown you? Do you get fired? Does something happen to you if I just continue to deny and you continue to properly chart it? Or my understanding would be that you would just, as the practitioner, all you can do is document. And then I come in at, 38 and a half weeks and I'm in labor, and and I'm still saying, no cesarean. At what point, do you see what I'm saying? Like, where's the line for this?
Well, you're going to get badgered beyond belief by a system that doesn't do that. And your doctor's going to be nervous as hell because that doctor may not be the one on call and somebody else is on call when you come in. And it's going to, what the F were you thinking? That's it. Because they don't respect individual patient autonomy. He could say all he wants. Well, listen, I counseled her every time she came in, I counseled her and she chose not to listen to what I'm saying. What would you want me to do? And again, because of the ethics rules, you're not supposed to threaten child protective services, or you're not supposed to, threaten NICU admissions or threaten mothers, but they do it all the time. And I don't know that there's too many women who are powerful enough to withstand the kind of gaslighting that you would get. I mean, there are some. I have stories of women who've from what I learned and what my friend David Hayes taught me about mono twin research is there's not a lot of research on mono twins. The standard teaching is that mono twins get hospitalized at 26 weeks. You sit in bed in the hospital for 6 weeks, away from your home, away from your partner, away from your children, away from your dog, on the monitor. At 32 weeks, you get steroids. At 32 weeks and 2 days, you get a C-section. That's how they're treated. And if you asked 99 OBs, they would say that's how you treat it, because it's so dangerous, because the cords will get twisted up and tangled and the babies will die. But if you look at the literature in the world, which isn't much, that's actually everything I just told you is unnecessary or untrue. 100% of mono twins will have cord entanglement, which means the cords are all twisted up. Babies don't die from cord entanglement. We picture that, it's going to be pulled into a tight knot. But how? The babies are sitting right next to each other. How is a cord going to be pulled into a tight knot? Now, when one baby comes out, theoretically, you could start to see some compression of the cord, and maybe B might get in a little trouble and that sort of thing. But there's no reason to bring them out prematurely. There's no benefit to hospitalization over home. There is to the hospital. Think about the revenue generation of keeping someone in the hospital for 6 weeks and monitoring them every day and doing ultrasounds twice a week and whatever. That's a huge amount of revenue. None of that is actually going to improve outcomes. Because if babies again, we're spending a lot of time on something that's so rare, but if mono twins make it to past 22 weeks, the likelihood that they're going to have a problem is very rare. They're going to say there's a very high incidence of twin transfusion syndrome in mono twins. The literature doesn't support that. There's a 15% risk in mono die twins, but apparently from the literature, there's almost no risk in mono twins. People ask how that is, and I'm not going to get into the anatomy of the placenta and stuff like that, but the traditional thinking is wrong. Yet trying to get conventional policies to change is really impossible.
Yeah, it's like a 10-year lag or something like that in research to policy change, correct?
Well, what's really interesting, you said that, they say it's 17 years is what they said, but The Trim Bridge trial changed things in 3 months. The Arrive trial changed things in months. So if something is changing that may decrease revenue, or maybe they appears to imply greater risk to the hospital or the doctor, that may take 17 years to change. Or 50 years. We can talk about continuous fetal monitoring. It's been around for more than 50 years. It was designed, supposedly, without research, that it was going to prevent cerebral palsy or interpartum death. It has done neither. What it has done is it's increased intervention rates by 4, 5, 6, 700% with no benefit to the baby. Yet in every labor and delivery ward in the hospital, they're going to tell you need to be monitored. The problem is that on occasion, monitoring will pick up a problem and will save a baby. But what's it doing to the other 99+%? How many of those are getting things done to them that they don't need to be done? And there's a thing in medicine called the number needed to treat. And how many women need to be intervened upon to save one baby? And ultimately, that decision doesn't belong to the hospital or the doctor or the insurance company or the lawyers. It belongs to the well-informed or not so well-informed woman. You can have informed consent, informed refusal, and you can have uninformed refusal. A woman can say, I don't want to do that. And you say, well, let me tell you why you should do it. I don't want to know. Just not doing that.
And you as a doctor just chart that, right? And then that should be the coverage, because we have accountability as humans that we can take.
The problem is that people don't always take accountability for it. They'll choose a path that maybe wasn't recommended, and then things will go bad, and then they'll blame somebody for not being forceful enough, which is why doctors are caught between a rock and a hard place. I understand it. If I was a doctor just working as a cog in a wheel, I would just keep my head down. So I get my Christmas bonus, I get my salary, I keep my job, I get promoted. Why would I want to rock that boat? For what? For a patient that I don't really know, because I'm not invested in her. I went into obstetrics for something called longitudinal care. It's the main reason I picked obstetrics, because there's only internal medicine and family practice and OB do longitudinal care, where you take care of the same person over years. All the other specialties, pretty much, you fix a broken arm, you take out an appendix, that sort of thing, you never see them again. Well, they've changed. They've taken that away from most obstetricians. You may see somebody in your office, but you may not be the one that actually sees the culmination of the process, because someone else delivered that baby. Or you may be with her in labor, and then it's 7 o'clock in the morning and your shift is over and you go home and someone else delivers that baby. Or you end up delivering people that you've never met before. That's not longitudinal care. That sucks from the point of view of, for me, why I would never work in a system like that. Also, when you're in a system like that, you rely on your other colleagues to be as diligent as you are. And I can tell you from my experience when I was a young physician covering emergency rooms and labor and delivery units, just trying to build my practice and make money, that I would come in sometimes and find that there were women on the ward that hadn't been seen in 2 days. And there were women in labor that were having deep variable decelerations. And the doctor who was on call had gone home an hour before my shift started. He just left. And nobody seems to care. Now, are these exceptions? I don't know. I've seen enough errors in the hospital, and I've seen enough of situations like that where mistakes were made or people were just lazy to wonder, is it errors, or is this the system just fosters things like this?
Electrolytes are trending, yes, but they have been in need of our human bodies for all of time. And if you're drinking another popular and delicious salty electrolyte, here's why you should be drinking Relight instead. First of all, have you ever considered the salt source of these other brands? Because most of them just use table salt. Yeah, table salt. You don't want that. Redmond's Relight Powders uses their unrefined ancient sea salt that they mine in Utah. This salt source contains 60 plus trace minerals along with calcium, chloride, potassium, and magnesium in 2 different forms, glycinate and malate. The minerals that they use in the Relight powders are all in the appropriate proportions and forms too. The metabolic needs of pregnancy, healing postpartum, and milk making require more minerals than in other times of your life. Pregnancy itself demands huge increases in your blood volume, which takes, more minerals. Relight is the perfect blend to be sipping during your pregnancy or during your labor even, and especially while you're breastfeeding. It tastes amazing, and my favorite flavors oscillate between mixed berry, lemon lime, and the strawberry lemonade. But you can try a sample pack and try all the flavors for yourself and see what you think. Use code HEALTHYMOTHER to save 15% on your entire Redmond order. That includes their OG sea salt, other seasonings, bentonite clays, toothpaste, and more. Yeah, and you mentioned too of, this is kind of like one of my hills to die on, is the it's a little bit unrelated, but still the idea of longitudinal care and the lack of that with hospital lactation consultants, because they don't ever get to see if their advice was right. There's no learning for them of, oh no, this baby's not tied. And then watching to see, was that breastfeeding relationship successful? What was going on? Did that work? They have no idea. And so they'll say these things, or they make claims or whatever. And there's no learning on this part of the practitioner of following along with the client.
Your listeners need to understand that the hospital system is not set up to benefit that individual woman. The hospital system is set up to benefit the hospital system. It's to maximize revenue, minimize liability as they see it. And that's what it's for. And that's gets us into something called fiduciary duty.
What? Say that again?
Fiduciary duty.
Okay, what's that?
An example would be you hire a lawyer. Your lawyer's fiduciary duty is to you, the client. Hmm. It's not to anybody else. He or she is supposed to be, the duty. They owe a duty to you as the client. As a physician, our fiduciary duty is to our patient. But when a doctor is an employee of the hospital, now his fiduciary duty is conflicted. Because if it's to the client, but the hospital doesn't want him doing certain things, maybe he's going to skew his counseling. So it's been skewed. It's been altered, and it's not true anymore. And the fiduciary duty of the hospital is not the same as the fiduciary duty of the doctor. The fiduciary duty of the hospital is to keep the hospital's doors open and to make profit and revenue. So the chief financial officer of the hospital has no reason to desire to lower the C-section rate in that hospital, because that's going to cut into the hospital's revenue. Whereas the doctor may want to do breech delivery or may want to do VBAC, but that hospital doesn't support it. They should support it because it's an evidence-based choice that the woman should have the right to do it. But that hospital isn't going to do it because their duty isn't actually to the patient. Yet they'll have nice commercials on the radio and stuff. People don't listen to the radio much anymore, but I'm dating myself. But they'll have nice advertisements, and they'll say how they want you to thrive and they want you to do all these things. They really don't. The individual administrator probably isn't mean. The individual doctor isn't probably mean. The nurses aren't mean, but they're in a system that makes it so.
Yeah, and it's a business. And I think people really don't want to confront that idea.
No, they don't. They just need to know that going in, that that's what you're dealing with. And that's why you need to plan for your birth the way you plan for other things in your life, like moving or a wedding or buying a car. You do more research in buying a car than you do in how you're going to give birth. And then we miseducate people too, because we don't teach them when they're teenagers about their bodies, their menstrual cycles, what pregnancy's like, the normalcy of nature's design. We don't teach those things. So then they come out and when you don't know something, you're easily manipulated. And you always fear what you don't understand. And so it's easy for doctors to say things like, well, if you don't do this, then, your baby could die. When somebody says that to you, it's game over as far as a pregnant woman goes, because the most thing she values most in life is getting that baby out safely and having that baby in her arms.
Exactly. I always liken it to talking to the cops. Unless you have an extreme knowledge of the law, you get pulled over by a police officer and you're unlikely to confront, argue against, deny, refuse anything that they say. It's the nature of the power dynamic. And it feels to me, I'm very visual, and in my head, I see this is a very fine line. It's like the difference between being above water and below water. There's a fine line where it could be in a hospital system. OB-GYNs who are working with the patients, who are having a relationship with them as much as possible, although I do understand that it's much more difficult than in a home birth midwife setting where you take on a certain number of clients. You're definitely going to be there for the birth, like whatever, but they still could have some level of more relationship. And then also this just understanding of informed consent, autonomy, and liability to the doctors too, where if you chart that you've done this and then something horrific happens and the woman had denied your advice, that you're safe. There's not a malpractice suit that can be, and this is where it gets very sticky because the doctors are afraid, and it's not fair to them when there's a situation where they've tried to make the best Because there are going to be these one-off situations throughout history, right? Where it kind of ruins everything. Like there's one situation where a doctor got their license revoked and, all their money was gone for the rest of their life and it totally ruined their life because of a situation where they did not force a woman into what they thought maybe should have happened and then da-da-da. And that is wrong because there should have been an accountability on the side of the parents where if they make a choice and something goes wrong, it's not the doctor's fault. There is a certain level, in my opinion and view, and I know it doesn't really work out that way, but I wish it could. It's like we're so close. That's like that line I'm talking about between air and water. It's like we could be so close, but instead fear has driven things, money has driven things. And so on the part of the parents going into the system, you just have to really know this and own it and understand it, not fear it, but be very, very well prepped. And this is the whole role of doulas, staying at home as long as possible, understanding your choices, making, just giving yourself more time, not being coerced into unnecessary inductions, la, 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 la. It's a lot to know. It's a lot to understand. It's not something to only think about 2 weeks before you're going to go into labor. And as you said too, we're not educated at all during our lives. And as a woman, it's like all you see in the media for your entire life, or all you hear is these horrific birth stories and how painful and terrible it is and how amazing epidurals are, or how amazing their scheduled C-section was. Or, you hear about countries like Brazil where almost every single birth is planned cesarean because they don't want to, have the unpredictability of when their babies are going to come, and all these different things that equate and add up to this general this is my word, socialization. There we go.
Socialization. That one I can say.
Socialization of us as little girls becoming women.
Anthropomorphization. Oh, I got that.
Yeah. Where we have no ownership in a beautiful way, in an honorable way of like, holy shit, I get to do this. This is amazing. I get to go through this as a human. And so many people don't get to do this. And it is going to be hard. I'm sure it's going to be challenging. It's going to be my dark night of the soul. It's going to be psychedelic. I'm going to transform. I'm going to reach places where I didn't think that I could go. And I'm still going to just do it because this is how all of humans have gotten here at some point in the future. And to view it in that excited, empowered, confident, calm way, and to understand that picking your provider is your like number one thing that you can do, whether to influence your birth in a proper way, right? Like that's my goal, is educating women to see how beautiful and amazing this can be and to inspire them to get excited and get amped up about it, because I think it is really amazing. And it's just so sad because it could be one of the most transformational, beautiful things in a woman's life. But so many times, as you said, they're uneducated. They go into the hospital. They have no idea what's going on. They just listen. They're winging it. They have usually some sort of a level of, well, maybe not usually, but a lot of them will have a bad experience. Then with their subsequent pregnancies, now they're choosing out of hospital birth or some sort of a different situation because they're like, whoa, I don't want that to happen again. And it's just unfortunate that we have to go through this thing. And it's so obvious too, from on the outside perspective, like you and me, to see working with these like populations, it's like, oh my gosh, you guys, it doesn't have to be like this. And then also, I know that the OB-GYNs and the labor and delivery nurses are not set out. They don't wake up every morning. They're like, can't wait to screw up people's lives. They don't have that thought, but we have to understand that the way that things are going in the system right now is not supportive of physiological birth in a lot of different ways and for a lot of different reasons. And unless you're advocating so hard and so consistently, and you're really doing things differently, it's going to just chug along and continue. And it's probably only going to get worse really as time goes on. So I want people to know, like my goal with this episode is not to just continually bash on hospitals. It's to say, you guys, there are problems. We have to recognize that there's problems and not be offended, and to be able to talk about the nuance here of the problems and to say, here's some solutions, here's some ways to do it, like some things to be aware of so that it can go better for you. And if you're somebody who's pregnant with breech or twins, know that there is different options for you too. It doesn't have to be only a cesarean option. There is people like Dr. Stuart has trained, who would be willing to do it.
Yeah, I just thought, it's very well said. And that's why you have a podcast like this, is because you want people to understand that. And if we affect one family at a time, then we're doing some good. We are fighting a monster. The old golden rule, them that has the gold makes the rules. These people have 98% of the market, and they're not really likely to let go of it. They're fighting desperately. The problem we have in obstetrics with all the 35% C-section rate, the 30% induction rate, the 10% of babies going to the NICU, the epidural rate, all the outcomes getting worse, is not because 1 or 2% of babies are being born at home. And I just saw something today on Instagram, I think it was this morning, a little meme that said, when something goes wrong in the hospital, there's a problem with birth.
Yes.
That's the way it's treated, right? As opposed to, it's not, they never say it's a problem with hospital birth. They say that's a problem. That's a known problem with birth. If it's at a home birth, it's because you were in the home, which is very rare to be something that goes wrong at home, that things are more likely to go wrong in the hospital. I just want to say that. I also want to just elaborate a little bit more on what you were saying about the system and the doctors in it. You said you don't want to just bash on hospitals all the time. I will. Because until they start changing, they deserve bashing. And the people that are in it, the doctors and nurses, even though they may very well be good people, what's the thing? All that's necessary for the triumph of evil is for good men to do nothing. If you're sitting in a system that is getting worsening outcomes, and you're doing nothing because you're part of that system, you're just as guilty as the people that have put it in place in the first place. They need to stand up. And I can tell you that most of my colleagues are not happy. How many of you know a happy obstetrician in today's current system? And why? And how do I say that? I've said this a lot of times lately now. I feel like a broken record, because happy people don't treat you like we've just described over the last hour. They don't tell you, they don't pull out the dead baby card. They don't scoff at you when you have a difference of opinion. They don't roll their eyes. They don't stomp out of the room. They don't threaten you with child protective services. Happy people don't do that. So why are doctors unhappy? Well, because they've spent a decade or more of their life to do something only to come out to basically be cogs in a machine with no ability to be independent. And again, they get satisfaction. You get satisfaction from catching a stranger's baby. You get a lot more satisfaction from catching a baby from a woman in a family that you've known, and catching her second baby and her third baby and her fourth baby. That's why if you want to be up at night for those sorts of things, you get much greater reward. The system doesn't allow that anymore. The system doesn't allow doctors the time to develop a relationship or to give adequate counseling. When your appointment book is made by administrative people and you have to see somebody every 8 minutes, so you're seeing 6 or 7 people an hour, and then you have time to pee, okay? And you don't have any time to chart, so you got to do that later. How in depth in counseling can you get? I mean, we're off the topic of Breech and twins, but I just want to say that my partner, who I love dearly, used to see about 40 patients a day or more. I would see 10, maybe 12 in a day. And I asked him sometime, how do you do that? And how do you see somebody for their annual pap smear in 5 minutes? And he said, well, it's not hard. We talked, because he had a knack for making people feel like he gave them a lot of time. But I said to him, what happens if somebody comes in for an annual exam and they tell you, you find a cyst on their ovary, or they come and tell you that they think that maybe their husband's having an affair? How do you deal with that in 5 minutes? And he says, I don't ask. That's his response. He's a good doctor. Patients love him. He's retired now, but I don't ask, because he doesn't want to find out that information, because he doesn't have the time to go into it. And if he finds a woman who's got a cyst on her ovary, he'll tell her to make an appointment, come back next week. So now for a week, she's got stress about a cyst on her ovary, when in my practice, I would tell her, you got a cyst on your ovary, let's take a look at it. Oh, this is a simple cyst. It's likely to go away when you get your period. Come back, in a month, and we'll take another, we'll do another exam and feel it again. Or this is a complex cyst, and now we need to do a little bit more studies or whatever. But don't leave them wondering for a week. I still remember I've seen patients who had Kaiser insurance in Southern California. They went in for like their 10-week visit. They couldn't find a heartbeat. So they scheduled them for an ultrasound in 2 weeks. So their friend or their doula would call me and say, Stu, can you see this person? And I said, sure, bring her and have her come over right now. And we'd come over and we'd find a heartbeat, or we'd find a blighted ovum or a fetal demise. But to make her wait for 2 weeks is unconscionable. And happy people wouldn't do that. So change the system. If you're in that system, don't settle for that. You're not guilty because you're not the cause of it. You're part of the system.
It's a stripping away of humanity. It's like we just cannot maintain our humanity and depth of care and love for everybody in that sort of a situation and setting. It's like not the same thing at all. I know some people are going to come at me for this, but it makes me think though about, well, what's another major stripping of humanity that I've pondered on in the past, to use as an analogy, is people who work in slaughterhouses, or on feedlots with animals where they're, you see the clips and it's horribly abusive. And you're like, how on earth, who are these people who wake up in the morning and that's where they go? And then they are doing this with animals. And then I eat meat. I'm not like a vegan, but I could never go and be that person. And at first, I'm sure for that person, it was really hard. And at some point you numb out, you just turn off, and you can't care that level of depth for every single person. And I think there's got to be something like that with these 12-hour shifts and these 40 patients in a day. I cannot even imagine. There is no level of, it's just not even, it's like, I don't know, it would be like torture to try to expect yourself to be able to give what you would want to give to them. So then you can't. And so then you're disappointed in yourself. So you say, okay, well, I'm just not going to. I'm going to kind of shut off. And it all becomes sort of robotic and AI. I mean, AI is going to take over that in a hot second. Like the beauty and the genius in birth work is that this is an extremely transformational process that a woman and a family is going through. And it can be something where, those doctors, nurses, or midwives are people who she never forgets in a positive way. They never forget the experience that they had and how well they were treated and how beautiful it was and how they were listened to and how they felt seen and heard and part of the process, even if it was a pivot from their plan, even if it was, gosh, for some reason, this is not happening. I think that we need to, go for C-section or whatever. Or I know you really didn't want to be induced, but here we are. We need to talk about that now or whatever. It can be so different when you're part of it and you're seen as a real human and not just room 317 who's already been here for 17 hours. Like, I just wish and want that for everybody. And so anyway, Dr. Sue, I'm going to let you go here, but I really, really appreciate everything that you do in your work. And I think that it's just something that in the future, I do see there being a difference as long as people are willing to do what you just said, which is break the system, pull out from being a cog in the wheel, and don't be compliant in it anymore.
Yeah, make this as important an event in your life as it could possibly be, because you will remember it the rest of your life. You'll remember the birth of your children, just about on your deathbed. As a matter of fact, Christopher Nolan wrote the lines, I think, in Interstellar, where the last thing you think about before you die will probably be your children. And for a woman, it's going to be the childbirth is going to be a very big part of that. And I'd like to see women have better memories. As you said earlier, many women come and seek out midwives at home birth for their second pregnancy because they're traumatized from their first pregnancy. Morgan, you're funny though. When we first started, before we came on today, you said, let's talk about twins and breech and ultrasound and free birth. And I think we got through breech and one fragment of twins. We didn't even talk about di or mono-di twins. And maybe if this is well received, you can have me back and we can do twins. And then because this is what happens when we start to talk about birth and we are, I don't like the word nerd. We're birth enthusiasts. This is what happens. An hour and a half goes by and it's like,
And this is why these topics have to be fleshed out in this sort of a setting, because it's too simplified to say breech is dangerous, go for cesarean, period. That's what they say. That's it.
It's also too simplified to say breech is not dangerous, have a vaginal delivery.
Right. Exactly. You're so right. We need to say, you ready for an hour and a half conversation at least? And that's not even, there's still so much that could be said about the whole thing. Well, why does breech happen? And all these different things. We can talk about it.
Well, midwives have the right model because they give prenatal visits and I do consults online and I book at least an hour. You can't do it in less than an hour. I mean, you can't. And sometimes we're done in 30, 40 minutes, but you really can't, because one topic leads to another topic, leads to more questions, and you need time to answer the questions and be sure that when you're looking at somebody one-on-one, which is why I like visual, I don't like talking on the phone, you can see whether the person is hearing what you're saying. You can just read their face. You can read their eyes. You can see you're nodding. So you get that feedback, and you can tell if you're getting through to somebody or not. And they can tell whether you're being honest or you're being deceptive by how you're talking and how you're looking at them. When you're in a room and the doctor's short on time or something like that, they're looking at their computer screen, they're looking at their watch, they got one hand on the doorknob. That body language just tells you that they're really not interested in you.
I just finished the book Frozen River. Have you read that?
Is it a fiction book?
It's a fiction. It's a historical fiction, but it's based on a true story it's by Ariel Lawson, and it's a midwife.
It's on my nightstand.
You would love it.
Somebody recommended it to me. I haven't gotten into it yet. I've got it's in a queue. Put it that way.
Yeah, of course. 100 books list. It's really lovely. And one of the parts in it, it's about this midwife in this little town. And it's kind of just in the...
That's why I got it. Yeah.
Yeah. In this time where MDs are coming in to do birth in this little town, home birth setting, of course, but she has all this experience and there's this like young doctor that's come in and there's lots of different mistakes that he makes. And she kind of has to save his ass a few times. And in one of the settings though, she comes into the birth and to help him because it's not going well with the woman. And the midwife asks the doctor, do you even know her name? And he's like, no, why would I ask that? And she's like, okay, well, let's just back up. And just the idea, again, back to the humanity thing of, I just think humans, one of our very unique distinguishing traits from a lot of other animals, although other animals have them too, but I think it is one of our main requirements to true happiness and health is our sense of community and working together, our compassion, our connectivity between each other. We're not solo animals. We're not, just out doing our own thing. We are really, really meant to be in community with each other and to feel deeply seen. And that, I think, and this is sort of also, this is reflected to me in the lack of mother-baby time in a NICU setting, where it's really not even that, it's not actually necessary. Or why can't a baby be receiving respiratory support skin to skin on mother's chest instead of it next to her in the bassinet? Why can't these little things be done? And it's like kangaroo care stuff with twins. It's like, well, duh. Fine. I mean, good. I'm glad that they finally figured out that they do well when they're together. And, these just little things that science doesn't want to, or it's hard maybe for science to prove it. But it's like, time out. Do we need science to prove every single little thing that we just know deeply in our hearts?
No. Because if science, a mentor that I used to listen to on the radio years ago, it said that science either proves what you already know or it's wrong.
Yeah.
Pretty much. It's very rare for science to suddenly undermine common sense. You don't need a study to tell you it's safer to cross the street when the light's green than when it's red. You don't need a study that. But to an academician, you can't say that. There's no study that says that. Blah blah blah. This is just what you were saying.
Modern times are weird times.
Well, one more thing I'll just add that you're right. I mean, hospitals spend millions of dollars on advertising. They spend millions of dollars on stupid stuff. Why is it that they couldn't get an architect? And architects, by the way, go to architecture school to design hospitals. They learn that in architecture school, how to design a hospital. Why can't they design a NICU such that that every baby that's in there's a bed and a chair, and so that the mother can be with her baby 24/7 as recovering from her C-section or her delivery, and be in the room with her baby in the NICU? Why can't architects design a NICU like that? It wouldn't be that much money to redesign a NICU floor. They might need a little bit more space, but Jesus Christ, you have better outcomes. We know you have better outcomes when babies in the NICU are skin to skin with their mother. And yet it's not done. Sometimes you got 4 babies in one quad, in 4 incubators with 1 chair in the room. And you got 4 sets of parents in there. And there's 1 chair. Who thinks this stuff up? Not humans.
It's purposeful to disencourage. It's like they don't want to deal with the complicating factors, more factors in the room, more voices asking questions, doing things.
Probably so.
And it's like, guys, but what's the most important thing? I do get it. I get it. I can see it's one of my powers as a Libra, I think, where I can put myself in that position and say, oh my God, no. We don't want parents in here. Like no, it's going to be too much. If I'm a robot, if I'm pulling my heart away from the whole scenario.
Well, the NICUs often see the baby as their baby. I've seen the language been used. I mean, they sort of undermine parenting. We didn't even get to talk about fathers and the undermining of fathers either. But again, there's so much in this topic. We could do. This is why you have a podcast. I have a podcast. We have different episodes. I really appreciate the opportunity to be here today. So thank you for giving me this hour and a half to speak to you.
Thank you so much, Dr. Stu. Are you pregnant or you're trying to conceive and you're looking for reliable natural health information about how to have a healthy pregnancy and also prepare for the future steps in motherhood to come, like the birth, the breastfeeding, and the postpartum? Because I have got you. So this is exactly the reason why I made the 6-week pregnancy call. And it's my most comprehensive resource. It's the thing that I absolutely love. I've poured my heart and soul into it. It's all of the things that I wish that every woman knew when they are entering motherhood. It's a pregnancy health course, birth prep series, breastfeeding 101 class, and a postpartum planning course all in one. And normally I run it as a class with live Q&A calls, but now it's available in a content-only format so that you can purchase it at any time and start learning immediately. It's called the lessons-only format, and it is just only all of the video lessons that you'll get access to for forever. So log on to milkmedicine.com/lessons-only or check out the link in the show notes.
In order for others to hear this information, please leave a review with Apple Podcasts, subscribe, and share with a friend who would benefit from this content. Please remember that the views and ideas from this podcast are for informational purposes only and are not intended to be a substitute for medical care of any kind, including the diagnosis and treatment of any disease. Consult with your provider before integrating any of this information into your own healthcare plan. A healthier future starts now, and it starts with you.